And now, to wrap things up, the last topic is new treatments for thrombotic APS. The treatment of thrombotic APS has changed very little over the past 30 years, and that's because although anticoagulation remains the cornerstone of treatment, it doesn't really address the full spectrum of the disease, especially when it comes to microvascular and non-thrombotic complications. In recent years, our understanding of APS has improved, and increasingly inflammatory mechanisms have gained greater importance. And this has opened the door to new drugs that could play a role in this disease. The first group of drugs would be treatments targeting B lymphocytes, and for that we have rituximab, which appears to have been used effectively in case series for the treatment of severe thrombocytopenia and skin ulcers. And the EULAR recommendations, let's remember, include it as a treatment for refractory catastrophic APS. Another drug that I also found very interesting is belimumab, which again in case series has been used effectively for the treatment of diffuse alveolar hemorrhage and skin ulcers. And currently there is a phase 2 clinical trial on the use of this drug in patients with APS. Regarding complement inhibition, a drug that I believe is a bit of a trend, especially in nephrology, is eculizumab. This drug blocks C5 and therefore prevents the formation of the membrane attack complex and the activation of the complement system. This would be the dosage generally used in the CAPS registry, which is the International Registry of Patients with Catastrophic APS, but there is no clearly recommended dosage for these patients. And let's remember that it would also be part of the treatment for refractory catastrophic APS. This is based on results from the CAPS registry, which showed a positive response in up to 74% of patients. Therefore, it is a drug that appears promising for managing microangiopathic manifestations, especially in APS-related nephropathy. And finally, sirolimus, which is a drug that blocks mTOR. We know that it is a drug very extensively used in nephrology, in this case for immunosuppression in kidney transplant patients. And it seems that in patients who are antibody carriers and have livedo reticularis, the skin biopsy, an increase in the activity of this cell cycle regulator has been observed, which would enhance T lymphocyte differentiation and proliferation. And it also appears that in patients who have received a kidney transplant due to APS-related nephropathy, the use of this drug reduces microangiopathic lesions in the kidney biopsy. Therefore, further research is needed in the future to explore its potential use in microvascular manifestations. And to conclude, antiphospholipid antibodies are key in the pathogenesis and diagnosis of APS. Although we have seen that some non-criteria antibodies may play a role, more evidence is still needed to determine in which cases we could use them in routine clinical practice. Regarding refractory obstetric APS, remember that we have drugs that seem to have a role in the management of the disease, especially hydroxychloroquine. Others, with less supporting evidence, such as corticosteroids or immunoglobulins, when combined with standard treatment, may improve obstetric outcomes. As for direct oral anticoagulants, they are not recommended in the management of thrombotic APS due to the high risk of arterial thrombosis. And finally, the new drugs that open the door to a different and new perspective for the management of IPS. And this is the bibliography, and that's all. Thank you very much.